Hello everyone, let me introduce myself first. I'm P.VASUMATHI SRI, Assistant Professor in the Department of Clinical Nutrition and Dietetics at Theivanai Ammal College for Women. I'm here to discuss about enteral nutrition. What does enteral nutrition mean? So basically enteral means inside or within or by the way or by through the way of gastrointestinal tract with the use or via gastrointestinal tract. So many patients with functioning GI tract do not or cannot eat a sufficient amount of nutrients by mouth, which means whomsoever the patient or people with functioning GI tract, functioning gastrointestinal tract will not able to eat through the mouth. They cannot take food orally for whatsoever reason it may be. But their first option should be providing adequate nutrition, and it should be deliver nutrition orally. So a first priority should be delivering nutrients orally. If the oral intake is not possible, if the oral intake still remains suboptimal, then only we have to start with tube feeding, like the tube feeding but with the use of gastrointestinal tract, which can be initiated to meet nutrient and energy requirements. Current EN guidelines, that is enteral nutrition guidelines, currently what they are stating is you have to ensure you are providing enteral nutrition, and it should be initiated within 24 to 48 hours, that is within 1 or 2 days. And you have to check whether the patient here is in the head of bed, like the elevation of the bed or the patient's head, to check or prevent the aspiration. And this can also be done by passing the tube into the stomach or the duodenum through the nose, that is called nasogastric feeding, which means when the patient is not taking orally, then you are initiating tube feeding. For the tube, you are giving or you are passing a tube into your stomach or the duodenum. It starts from the nasal but it ends at the stomach or the duodenum. It can also be directly inserted into the stomach via gastrostomy or jejunostomy feeding. Now we can see the routes of administration. So tube feeding, this can be done by different routes. The first three routes are nasogastric, nasoduodenal and nasojejunal, where everything starts from the nasal and passes via esophagus and it ends in gastric, that is called nasogastric, and the ending point at the duodenum is called nasoduodenal, and the ending point, that is the third point at jejunal of the intestine, that is called nasojejunal. And if the tube that is directly inserted by surgery from sparing your or tearing or cutting your skin from the outside and getting it passed into your stomach, that is called gastrostomy tube, and to the jejunum directly, that is called jejunostomy tube. So here nasogastric and nasoduodenal and nasojejunal, these three are termed as short term, and gastrostomy, jejunostomy are termed for long term. So we can see the feeding pathways now. Can the GI tract be used? When the GI tract is functional, then you should definitely go for using enteral feed. It may be tube feed or oral feed, but first the test should be oral food. So if you are giving oral intake and it might be clear liquids or full liquids, if the patient tolerates, then you can continue and proceed to the next routine hospital diets. But if the oral intake is less than 75% of the intake, then you have to initiate tube feeding. Or else, if the patient, when you see the patient, when you get to know that the patient couldn't tolerate orally, then directly you can start with tube feeding. So tube feeding is initiated, and if the tube feeding is exceeding more than 3 to 4 weeks, then you have to go for long term, that is gastrostomy or jejunostomy. If the tube feeding is lesser than 3 to 4 weeks, then you can go for nasogastric tubes, that is short term. And all these enteral feeds are completely used. And if you cannot use any enteral feed and patient is not tolerating orally, patient is not tolerating enteral, then the option should be parenteral. That is after the trial of 1 to 7 days of enteral feed. If that is not happening, when you get to know the patient is malnourished at the time of admission in the hospital, then you can directly start parenteral nutrition within the 3 days. So parenteral nutrition probably it should be started only after 7 days of initial trial with enteral nutrition. When the patient doesn't tolerate enteral nutrition, then only you have to proceed with parenteral nutrition. Parenteral nutrition is also having two types. One is short term and another is long term. Peripheral is through your hands or there, which means the tube will be shorter, so that supports peripheral. And for long term you have to go for central vein, which has larger amount of or bigger amount of tube size, and many of the nutrients can be given. Next, a satisfactory tube feeding must be. How should a satisfactory tube feeding should be? One is nutritionally adequate. What do you call as nutritionally adequate? So we have to ensure when we are giving patients tube feeding, if you are going through full liquids, you have to ensure whether that is fully adequate, nutritionally adequate, either from the side of macronutrients and also from the sides of micronutrients. You have to ensure whether all those are present and all those are meeting the requirements of the patient, and it should be well tolerated by the patient. So it should accommodate the patient's tolerance level too. If the patient only tolerates clear liquid, in there if you are trying for full liquid or semi-solid, the patient surely couldn't able to tolerate. At those times you have to give preference to the patient's feeding type, like tolerance type. Then it should be easily digested. Whatever you are giving, it should be easily digested. Why? Because the patient is already having a disease condition or having a intolerance where he couldn't able to chew harder foods, so that we are preferring tube feeding. So in that times the patient should have easily digestible foods. If it was very harsh or hard, then the patient couldn't able to tolerate or digest the greater or larger amounts of food particles. Then it should be easily prepared. The mechanism, like how you are preparing any types of feed, it should be easily prepared. It should not involve too much time, so that you have to give too much attention to the feed. For example, if you are giving hourly feed, like 1 hour each hour a feed, or twice second hourly feed, at those times you cannot give too much amount or attention to preparing, because you have to give next feeds. If you take too much time for cooking and preparing itself, then you couldn't able to follow the interval correctly. So, and it also should be inexpensive. If it was too much, then too much of cost, then patient couldn't afford. So most probably a coupling like mixing of supplements along with the kitchen feeds would go well in patients improvement, not on the bias, like either on the kitchen feeds or on the supplements. So indications for enteral feeding. What are the indications for enteral feeding? Traumatic brain injury, when patient is impaired or conscious or reduced or induced coma, prevents safe eating. Like for example, if a patient has done with craniectomy, then the patient's GCS will be very low. At that times the patient cannot wake up and eat. Those times we will be giving Ryle's tube feedings or NGT feeds. Then stroke. When the patient is paralyzed, they have dysphagia where they cannot swallow foods. So those times also we can prefer enteral feeding. on the starting. If the oral tolerance improves, then we can proceed with the next stages of the feeding types. Then dementia. So some patients will have dementia, which means they couldn't remember what they are handling. So patient, if they don't follow or don't able to eat from their hands, they also require tube feeding. Then gastric dysfunction coupled with malnutrition. For example, if a patient is already having a gastric dysfunction, gastric disease or ulcers, on that time if they have malnutrition, surely they couldn't be able to tolerate. Why? Because they already feel general tiredness or weakness will be associated along with that. And when there is gastric dysfunction or esophageal dysfunction, and at those times they couldn't able to tolerate foods, they'll omit, firstly they'll omit the foods. During those times we have to introduce enteral feedings. And other indications including post treatments like post operative sessions, or when the patient is having mechanical ventilation, when they feel difficult to breathe, then how could he able to chew and eat? So those times when you are preferring enteral nutrition, their digestion as well as their nutritional needs will be met. Then the patient who are chronically ill, for them also you can prefer enteral feeding. Okay, we know the short term and long term accesses, but what are the pros and cons of those things when we have to use? Okay, firstly, nasogastric tube. When you're taking nasogastric tube, it is short term and it is easily placeable because of their sizes. It has many sizes, but it is not indicated for bleeding disorders or facial fractures or esophageal disorders. Why? When the patient has esophageal disorder, for example, if he is having esophageal cancer or inflammation in esophagus, if he is already having esophageal inflammation, then is it possible to place a tube inside from the nasal to the gastric via or through the esophagus? Is it possible? It will make the irritation more, and it is not suitable to place the nasogastric tube there first. Orogastric tube. So it is also short term use, and it lowers the incidence of sinusitis than NGTs, which means when you are implementing the tube in the nose, it will create some allergic reactions or sinusitis. It reacts with there, but here the possibility of getting sinusitis is less. It is not tolerated for longer period of time in alert patients. Why? The patients will remove the tubes from their hands, so it is not tolerated there, and for it may also have oral infection or it may damage your teeth. So these are the cons for orogastric tube. Nasogastric tube, nasoenteric tube, which starts from the nasal and enters or ends in the enteric, which means the intestine, colon. So it is smaller in diameter, it is adjustable, and it can be delay the gastric emptying. So when it has to travel long time, so there may be a delay in gastric emptying. And also the cons, it may be difficult to position because it has to enter the exact end point, and it is smaller in size, but the administration of sub medications may be difficult, and the infusion pump is needed. Like for when the patient needs smaller tubes are inserted to the intestine, the patient might feel discomfort there. First thing. Second thing, when the medication has to travel long to the intestine and then diffuse, it is also little much difficult. And third, it needs infusion pump to settle down there, to position there. Then oroenteric tubes, it is same as orogastric tubes. Whatever pros or cons we saw, like it will it has lower incidence in sinusitis, and for cons, it might damage or it might create an oral infection. So gastrotomy tube, it is long term because you are not using your esophageal or upper GIT, you are using your lower GIT. So it is easily replaceable, and you're directly feeding to the bolus without disrupting the upper GI tract. So these are the pros of gastrostomy, and compared with oral and nasal route, this technique is more invasive, which means it needs more time, and also it is little expensive. And when coming to jejunostomy tube, so it is also long term use. It decreases the risk of food and fluids passing into the lungs. So here you are directly inserting the tube to the jejunum, where it prevents the risk of allowing the fluids or foods passing into the air pipe. And also the same thing like gastrotomy, it doesn't disturbs the upper GI tract. And what are the cons? It is technically more difficult to place. When you are inserting to gastrotomy, when it is gastrotomy, you will be placing in the stomach. So it is little bit easier compared to jejunostomy. But in jejunostomy, you have to find the place and you have to exactly place that. So that is little complicated. Next, is the nutrition what we are giving through the full liquid, is that all enough? No. Why? Because from clear liquid we'll be approximately giving only 300 kilocalories. Through full liquid we'll be giving only about 1200 kilocalories. But when the patient's requirement is larger or greater than 1200 kilocalories, then we have to go selecting for formulas. We have to aid formulas in the diet. How should the formula selection be? For example, enteral formulas, on an average, everything will be in the calorie content from 1 to 2 kilocalories per ml. All the formulas are composed of different sources of nutrients. But the standard or polymeric formulas include all the macronutrients and micronutrients, the major macronutrients including carbohydrate, protein, fat. So carbohydrates that comes from majority of portion is about 30 to 60% of energy in the form of sucrose or fructose, corn syrup solids, or carbohydrates. If you get to read the labels of the formulas, you could find that here same the carbohydrates gives only 4 kilocalories and 1 gram of carbohydrates. For protein, they provide 10 to 25% of energy from the protein sources, which includes milk protein, whey protein, casein, caseinates, or soy protein. Soy protein is plant protein. Then here the same, the protein, 1 gram of protein gives 4 kilocalories. And for fat, they provide about 10 to 45% of energy from the fat sources, including canola oil, corn oil, soy lecithin, safflower oil. Maximum they prefer MCTs. So here fat gives 9 kilocalories. And micronutrients, they pick micronutrients from the DGI or the recommended dietary allowance rate. So types, what are the types of enteral nutrition? Polymeric or standard formulas, it contains all the 3 or essential macronutrients and micronutrients. As I said before, all the carbohydrates, protein, everything will be in a balanced form. Example, they include cornstarch, then soy protein or whey protein, along with that any of the MCT. Then elemental is nothing but it is completely hydrolyzed. So the particle which we take, like if you are taking any carbohydrate, that is broken down and it is given in the form of easily absorbable. So if you are taking protein, then in elemental formula it is given as amino acids. So for example, any of the amino acids, essential amino acids or non-essential amino acids that required. And specialized formula. Here comes another one more type, that is semi-elemental, which is partially hydrolyzed. Not completely hydrolyzed but partially hydrolyzed. Patients who are not even tolerating semi-elemental, for them only we will be suggesting elemental. And for specialized, specialized in a sense disease specialized, for some person or condition who has any disease condition, for them we'll specifically suggest some formulas. For diabetic, we'll be giving patients with diabetic formula. If they are liver, then we'll be going for hepatic, like that. If they need high protein, we'll be suggesting high protein. If they want low protein, then we'll go for low protein. And modular contains only single macronutrient. For example, anything that is from carbohydrates or protein, only single thing which was needed or needed to be adjusted in the diet. Then kitchen feeds. Kitchen feeds are normal hospital feeds or homemade kitchen feeds, which includes simple milk, soy milk, egg flips, like that. So this is what all enteral nutrition is about. Thank you.